Okay, this is chapter 19, Blood Vessels, part 2. We're going to speak about hypertension. Last time we talked about mean arterial pressure and how to determine mean arterial pressure, and now we're going to talk about some problems associated with high blood pressure, different types. 90% of hypertensive conditions is high blood pressure. There is no underlying cause that's actually been identified, but there are quite a number of risk factors that can predispose a person to high blood pressure, and those factors include heredity, diet, obesity, age, diabetes mellitus, stress, and smoking. There is no cure, but it can be controlled if you restrict salt, fat, cholesterol intake, increase exercise, lose weight, and stop smoking. Many times this condition can be controlled, but if not, there are also a number of hypertensive drugs on the market that you can also take. Now, there's a secondary type of hypertension that's less common and represents less than 10% of all cases, and this condition is due to identifiable disorders, including obstructive renal disorders, obstructed renal arteries rather, kidney disease, and endocrine disorders such as hyperthyroidism and Cushing's disease that can promote hypertension. And really the treatment just focuses on correcting that underlying problem. Now, there are cases of hypotension, which is low blood pressure, and this is where the blood pressure is below 90/60 millimeters of mercury pressure. Now, remember when figuring mean arterial pressure, you take the diastolic pressure, which in this case would be 60, and 1/3 of the pulse pressure, which 1/3 of 30, the difference between 90 and 60, would be 10. So your mean arterial pressure would be 70. And all you need really is 60 millimeters of mercury pressure to have adequate perfusion to tissues. So even this low number here would not be a concern, only if it leads to inadequate blood flow to tissues. So it has to be a little bit lower than this to run into problems usually. So hypotension usually is associated with a long life and lack of cardiovascular illness. This is a diagram showing blood pressure variations throughout the systemic circulation. So when you start off from the heart, remember there is that difference in pressure, whether the heart's contracting or it's at rest. So your variable here is 120/80. There's your mean there's your mean pressure. Systolic is the 120, diastolic is the 80, and as you go through the arterial circulation, those numbers start to come together as the pressure decreases. So from the aorta to arteries to arterioles, now you're in the capillary beds, and you can see the average pressure in the capillary beds is around 20 to 30 millimeters of mercury pressure. Then the pressure continues to decrease back into the venules, veins, and then by the time you get to the vena cava, the pressure is virtually zero going back into the right atrium. So, and this is just showing you the color changes, oxygenated down to deoxygenated blood. The drop-off of oxygen occurs here in the capillaries. Now, some physiology, some terms. Resistance is a opposition to flow. Most of your resistance occurs in the peripheral circulation. So what causes the resistance is usually friction that the blood encounters with the vessel walls, and like I said, generally in the peripheral or systemic circulation. There's three important sources of resistance. You have blood viscosity, you have total blood vessel length, and you have blood vessel diameter. So when you're thinking of blood viscosity, you're thinking about the thickness or the stickiness of the blood due to the formed elements in that solution. So you have your plasma, but what really accounts for the viscosity are the red blood cells, because they make up most of the formed elements. And then you do have your white blood cells. You have platelets and you have your proteins, but the red blood cells really are the culprit usually. And where you have increased viscosity, it's a lot thicker, you have increased resistance, and it's less likely to flow. Now, total blood vessel length, the longer the vessel, the greater the resistance is encountered. And when you think of that third element about the diameter, the larger the diameter, the less resistance there is in blood flow. Now this picture is showing you the relationship between speed or velocity and what we call the total cross-sectional area of the vascular bed. So if you look at this picture and take it apart, you start off, the blood leaves the heart through the aorta, and then that one vessel is going to divide into distributing arteries, then arterioles, into the capillaries, and then eventually those capillaries end in terminal or post-capillary venules that will come together into veins, larger veins, and back into the vena cava, into the heart. So you start off with one, you end with one, but you branch all the way through. So if you look at the number of vessels, this picture here is showing you the total cross-sectional area of the vascular bed. So you start off with one, and you're branching and you're branching and branching into many, 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 so you can see all the different vessels. So they increase, and then when you go into the venous part of the circulation, now it becomes less and less and less to the vena cava. So here's what's happening. As the total cross-sectional area of the vascular bed increases, look what happens to the velocity. And down here shows you where you are in the circulation. So you start off in the aorta very fast, and then you go into more and more arteries, arterioles, and you see the speed drop. And by the time you get to the capillaries, look how slow it is. And think about it. The capillaries are 8 to 10 microns in diameter, and so are the red blood cells. So the red blood cells are going through single file. And you want the flow to be very slow, so it gives it time for the red blood cells to drop off their oxygen, for nutrients to be dropped off. And then after they pass through the capillary beds, then you see fewer and fewer vessels, and the speed picks up again. So it picks up going back into the vena cava. So the formula is that the velocity is inversely, it's an indirect proportion from the total cross-sectional area of the vascular bed to the velocity of blood flow. So it's an inverse proportion between the two. As the total cross-sectional area of the vascular bed increases, the velocity slows down, and vice versa. So spend some time with that. If you have to listen to this a few times until you really understand, that is the relationship. So blood flow, what you see here represented as capital F, is directly proportional to blood pressure gradients. Not in indirect proportion, but directly proportional to pressure gradient. And that little triangle means delta, and that means change in pressure. If the pressure increases, the blood flow speeds up. Now blood flow is inversely, this is another opposite now, proportional to peripheral resistance. If resistance increases, the blood flow decreases. So an inverse relationship, they work in opposition to each other. So this little formula puts it all together. And really, when you look at a fraction, if the denominator increases, then the value of the fraction decreases. So resistance really is more important in influencing local blood flow, because you can easily change resistance by either increasing or decreasing blood vessel diameter. And that's how blood flow is changed through the circulation depending upon what the needs are. If you're exercising, then more blood flow is diverted to working muscles. And if you're at rest, then the blood flow is diverted away from those working muscles to the digestive organs and the other viscera to maintain housekeeping chores. Now, there are some neural controls of peripheral resistance, and they maintain mean arterial pressure by altering blood vessel diameter. Now, if there is low volume for some external, extraneous problem that's going on, if you have some type of an injury or some type of shock and you're losing blood volume, then what happens is all the vessels are constricted except those to the brain and the heart. After blood distribution to organs, altering blood distribution to organs comes in response to specific demands, like I said earlier, depending upon what you need to carry out various activities. But under emergency situations, the blood flow really stays with the brain and the heart to maintain those vital organs during emergency situations. That's what I was trying to say, and sorry the phone rang there. Now, there are reflex arcs that involves things such as baroreceptors. Now, baroreceptors are receptors that respond to changes in pressure. And they work in conjunction with cardiovascular center in the medulla, vasomotor fibers to the heart and vascular smooth muscle, and sometimes also receive input from chemoreceptors. And a lot of these chemoreceptors are found exactly where the baroreceptors are located. They're right next door. And also higher brain centers, neural controls. Okay, so the baroreceptors, they're located primarily in the carotid sinus and the aortic arch, just for your information. Those are the larger vessels that are directly affected by changes in pressure. So here's the way it works. If blood pressure is elevated, then the arteries are stretched, and that stretch will stimulate the baroreceptors. They increase firing, and it hits two centers in the medulla oblongata. The cardioinhibitory center is stimulated, and inhibitory means to shut things down. So you do that by increasing vagal tone, because remember, the vagus nerve is the nerve that's associated with slowing the heart rate down. So by increasing vagal tone, you reduce the heart rate, which is going to help reduce blood pressure. At the same time, the vasomotor center is inhibited. That's the center that controls the diameter of the blood vessels. So you reduce the sympathetic tone, and remember, the sympathetic effect is to cause vasoconstriction. So if you reduce the sympathetic effect and reduce the vasomotor tone, now the vessels dilate. So by opening up the blood vessels in conjunction with reducing the heart rate, the net result is to reduce the blood pressure. Some other things that are controls are hormonal controls of blood pressure. So the following things increase blood pressure: epinephrine, norepinephrine from the adrenal gland, that's part of the fight or flight response, the sympathetic response. They increase cardiac output and vasoconstriction. I've highlighted angiotensin II because on the next slide I'll explain that. That stimulates vasoconstriction. High levels of antidiuretic hormone causes vasoconstriction. And on the notes, there's also something called endothelial-derived growth derived factors that are released from injured tissues to help expedite vasoconstriction, which results in vascular spasms, which is part of the hemostasis process. Atrial natriuretic peptide produced by the atria causes decreased blood volume by antagonizing aldosterone. And on page 7 of the notes, you'll see nitric oxide mentioned. It's used by the respiratory system to cause dilation for the release of oxygen to tissues. Inflammatory chemicals, histamine, prostacyclin, and kinins are potent vasodilators, and alcohol is another dilator. Okay, so now we're going to talk about angiotensin. Direct and indirect mechanisms for renal control of blood pressure. Directly, the kidneys can actually alter blood pressure themselves. In response to low arterial pressure now, you reduce the filtration by the kidneys because you get vasoconstriction of the renal artery and shut that down so that you can reduce flow through the kidneys. That's going to decrease urine formation. And by decreasing urine formation and you're losing less fluid through urine, now you're going to, over time, increase blood volume, which is going to increase mean arterial pressure. That is the kidney's direct mechanism for controlling blood pressure. Now, indirect, in response to decreased arterial pressure, now the baroreceptors are inhibited. This is opposite the flow diagram that I just showed you about how baroreceptors work. So go back and look at that again. This is the opposite situation. So now the baroreceptors are inhibited. That's going to increase nervous system activity, and you're going to increase renins released from the kidneys. Now, renin is a localized hormone. We didn't talk about it too much in the endocrine chapter because it really, we had a lot of other hormones to learn there, and I wanted to leave it here where we could just work on this one. But there's a protein in the blood called angiotensinogen, and renin helps with the process of converting that protein into something called angiotensin I. And then there's angiotensin converting enzyme that's produced by the respiratory system that completes the process of forming angiotensin II. Now, angiotensin II, we said, increases blood pressure, and this is how it does it. There's 4 different mechanisms. The first one is it targets the adrenal cortex to secrete aldosterone, which increases sodium reabsorption by the kidneys. It also targets the posterior pituitary to release ADH, and ADH will hold back water through the kidney circulation. So by holding back water and holding back sodium, these two work hand in hand. You're going to increase blood volume and thereby increasing mean arterial pressure. Also, you activate neurons that control thirst in the hypothalamus, and that makes you drink water, and then over time that'll increase blood volume and increase mean arterial pressure. And angiotensin II also targets peripheral blood vessels, makes them constrict, which is going to increase mean arterial pressure. So that's how angiotensin II indirectly has its effect on controlling blood pressure. So tissue perfusion is involved in several things, and what that term really means. It helps with delivery of oxygen and nutrients to and removal of waste from tissue cells, helps with gas exchange in the lungs, absorptions of nutrients from the digestive tract, and also is important in urine formation through the kidneys. And the rate of flow is precisely the right amount to provide proper function. Now, capillary exchange of respiratory gases and nutrients. How does this happen at the capillary beds? Well, most of the time, substances move by diffusion, from higher concentration to low concentration, down a concentration gradient. So oxygen and nutrients are higher in the blood coming into the capillary bed, so they move from high to low. They go from the blood to the tissues. CO2 and metabolic waste higher in the tissues, so they move from the tissues back into the blood. Lipid-soluble molecules can diffuse directly through the endothelial membranes because they're lipid-soluble, and like dissolves in like. Water-soluble substance passes through clefts, those intercellular clefts in the capillaries, and some capillaries having fenestrations, the little pores, they can go through there. And larger molecules, such as proteins, are actively transported in these pinocytotic vesicles and caveoli. So remember when we talked about endocytosis, taking larger things in through a vesicle, just making a little bubble that comes from the cell membrane. That's how those things are transported. So this picture looks a little confusing, but I'm going to really pare it down for you because there's 2 major pressures that are involved in getting substances out of the capillary bed at the arterial end of the capillary bed. You see this hydrostatic pressure, and the hydrostatic pressure in the arterial end of the capillary bed is higher. So it's 35 millimeters of mercury on average. Now there's a major opposing pressure, which is called the osmotic pressure. And what the osmotic pressure represents is that you have a lot more solute in the capillary than you do outside in the interstitial spaces. So where does the water want to go? Here's your semi-permeable membrane, very few solutes here, many solutes here. The drive is to pull the water back in where the solute concentration is highest. That's how we know osmosis works. But if the hydrostatic pressure overrides this, that's all you need. These 2 little pressures of the interstitial fluid, don't worry about those because they don't even amount to 1 millimeter mercury pressure. This is your major driving force right here. So at the arterial end, since hydrostatic pressure is 35 and osmotic pressure opposing it's only 26, your net filtration pressure is enough, around 10. It's enough to push your nutrients and oxygen out at the arterial end. Now, when you go to the venous end, across the capillary bed, the pressure drops. And look what's happened. Your hydrostatic pressure now is not as high as your opposing osmotic pressure. It's lower. So what does that do? Brings your waste products back in. So your CO2 and all your other waste products, your lactic acid, your urea and all that, that can go in at the other end because this hydrostatic pressure has dropped. So your major driving pressure that affects how things are going to move across the capillary is your hydrostatic pressure. That doesn't really change much at all. So there are factors that aid venous return. When we talked about pressure, blood pressure, and how it changes across the vascular bed, we said that it diminishes and reaches virtually zero going into the right atrium. So what makes the blood go back into the right atrium when a lot of the blood's returning anti-gravity? Well, the first thing you have is valves. Valves prevent backflow in the vessels, in the veins. Then you have muscular pumps, because a lot of these vessels are embedded in skeletal muscles, and those muscles, when they contract, milk the blood towards the heart, and then coupled with the valves prevent the backflow. There's something called the respiratory pump that's a little bit harder to understand, but what the respiratory pump speaks to is the pressure changes that occur during breathing that move the blood toward the heart by squeezing abdominal veins as thoracic veins expand. So when you inhale and the diaphragm contracts, it pushes down. So it compresses the abdominal cavity contents, which squeezes the veins coming through there and expedites the blood flow back into the thoracic cavity. When you inhale and you increase the volume of the thoracic cavity, that drops the pressure. It's another inverse relationship. And when the pressure drops, the vessels open up, and that expedites blood flow back into the right atrium. Here's a picture showing you contracted muscles, how it's squeezing on the blood vessel walls. The blood vessel that's distal to where that action is occurring will close, and then the one that's above it will be forced open and the blood's pushed upward. Now, circulatory shock is the last thing talked about in this chapter, and it's any condition in which blood vessels are inadequately filled and blood cannot circulate normally. And hypovolemic shock is the first one, and it results from a large-scale loss of blood. So any type of traumatic injury. Vascular shock results from extreme vasodilation and decreased peripheral resistance. So anaphylactic shock, sepsis from bacterial toxins, which result in vasodilation, another cause. And then cardiogenic shock is where the heart cannot sustain adequate circulation. Usually when you think about what happens in CHF, that's another condition.